Hello, hello, and welcome to the Balance Mama Project Radio. You are here with Dr. Say and Dr. Val, and today we have a special guest for you. We are here with Dr. Dani Kurlander, newly engaged. It is currently February 4th when we're recording. I don't know when you'll hear the drop. But she is a clinical psychologist. She specializes in health psychology with a focus on women's health concerns. So these include endometriosis, PCOS, chronic illness, pain, neuro conditions, and then connective tissue disorders. So she definitely takes an evidence-based whole health approach, which we love. And I love that she even mentioned before that health does not exist in a vacuum, and it does affect your relationships, your careers, your identity, and your daily life. She is based in Princeton, New Jersey. Dr. Kurlander also practices in New York, California, and other SIPAC states, as well as Jersey. And when she's not in session, you can find her at a local bookstore searching for rare reads or spending time with her dog. Hi, Dr. Dani.
Good morning, ladies. How are ya?
Hello, we're so excited to have you.
So excited to be here. I know it's been frigid over here for wherever anyone else is listening to, but hope you guys been warm and good since I've last seen you.
Yes, warm and cozy. I know, I know. Well, we are excited for this extremely important topic, and to just learn so much from you. I feel like you're a wealth of knowledge, and we always have great conversations. Ooh, I'm excited.
Yes, today's topics. So we're going to be talking about fertility challenges, reproductive health. And
Mhm.
so I'm excited to see from your lens and from the expertise lens, like, um, we'll say best practice, where people
Yeah,
land, how to be supportive for folks.
yeah.
And so before we dive in, do you mind giving us a brief overview of what endometriosis, polycystic ovarian syndrome, and what those are. And then at a later point, we'll define our geriatric pregnancy. I hate that term. I hate the term. Just know that I don't use it. But I have to say
Does anyone like the term? Like, it's
Oh,
just it makes you feel so old, so stigmatized. Like, it's not even true at this point, but that's a hill I'll die on another day.
yeah, yeah, I hear you.
But absolutely, starting us off, kind of brief rundown of endo, what it is, kind of what it looks like. So, couple different ways to describe endo, but the real basic of it, think of it more as like a chronic inflammatory condition. So, we're looking at this endometriosis, kind of like a tissue, almost like your uterine lining is growing on the outside. So it's not just on your fallopian tubes, it could be your bladder, your diaphragm. There's been recent studies that is potentially linking it to the brain as well. So it can grow other places, grow and grow other places is kind of the best way to put it. Now, when we're getting to symptoms, so we're really looking at irregular periods, longer periods, a lot of pain, a lot of different swelling. We're going to see infertility, we're going to see some fatigue. We're going to see some differences in body mass as well, and the potential for earlier menopause. So, a couple different things that we see that aren't usually kind of mentioned that I want to highlight here. And with good old PCOS. So, easy way to put this to more of a hormonal disorder. So, this is going to be more characterized by those irregular periods, different ovarian issues, metabolic concerns. So, we're also looking at some acne, some excessive hair growth. We also see insulin resistance and increased risk for diabetes, heart attack, heart disease, and those types of things as well.
Mhm. Thank you for sharing that. I feel like that was extremely thorough, and I love that you brought in the recent literature, specifically with the endo or the endometriosis growing and being in different places. We often think about it with the uterus, but there are other areas of the body that it can affect as well because it is just the lining of certain organs. So thank you for that. That was really big. And I feel like we're just now starting to see different therapies, different treatments for PCOS as well, and how that then can affect folks. I had a client the other day who was saying, I'm on this new PCOS medication, and now I have all of this energy because it has that effect on me. And so, anyway, it presents differently with different people, and there are still different treatments and things coming out. So, thanks so much. Um, and so, really quickly, I'm curious, when did you realize that women's health needed more attention from your perspective, from like a psychology and neuro lens?
Oh my gosh, it's a silly little story, but I also feel like it's so symbolic when I say this. So I used to work in the VA,
Mhm.
and the VA that I was in like the bit, shout out Saya.
Yes. Shout out to the VAs.
But with the VA that I was in, like I was in kind of the main medical center for the state. And I was doing all these evals. So where I was is I was in a very like neuro rehab place, which I'll get to in a second. And doing lots of evals, all these different things. And of course I would see women. There's women veterans out there. And it was one of those things where you would see these conversations pop up and I'd be like, okay, behavioral health, let's talk about it, etc. And it wasn't until one day I'm in this elevator, and it's not even like the big popular elevator. It's not like the big patient one. It's this side one that goes to the basement. It's a little bit creepy. Like you use it every once in a while. And there's a singular flyer in this elevator for like a women's focused group. So it's on infertility. And I see it change eventually, and then it's menopause. And I keep seeing this one psychologist trying to like really advocate and bring awareness to the group. But again, it's one singular flyer in a very like low traffic elevator. And I'm like, this is kind of crazy. And when I think of other VAs, like a lot of other VAs have big spaces for women's health. They have special floors, special entrances, all these things. And yet ours just had a flyer. And it got me really into this bubble of like, why do we not talk about it? Like, why do we not bring awareness to it? Why is it's still this like huge taboo topic? Especially for women too. Like, we have the voices to also bring awareness to it.
Mhm.
So I started kind of falling into more of that, like, okay, we need to have more conversations, topics, but it fell into this, like, how am I going to put my lens or like my spin on this? So my training's super neuro rehab based. And kind of what I was working with is a lot of traumatic brain injuries, polytrauma, so associate injuries. Now, the very brief rundown for brain injuries, we have traumatic. So, you get struck by something, etc. And then we have non-traumatic. So definition, internal factor. So I started thinking, kind of using this lens of internal factors. What about hormones? Hormones are internal factors. So it's a little controversial. Hang tight. I know, just bear with me with this. But putting it on the lens of like menopause, this is where I started getting more into it. And I was thinking, so if we get to menopause, there is this really steep drop off of hormones.
Mhm.
Dare I say an internal factor?
Yeah.
I know.
Agreed.
Mhm.
Yep. So this internal factor and leaning more into the neuro perspective, what we were seeing, it's not just hot flashes and mood changes and sleep problems. We are really seeing slower processing speed, memory lapses, things like this. And if you go to the imaging research, parts of your brain are shrinking. They're changing. Your white matter is changing. Your hippocampus is changing. So if we have this evidence that your brain is literally changing because of this internal factor, because of these hormones, it just kind of struck me as like, we are not doing any sort of justice by just being like, everyone goes through it, it's fine. Like, we need to actually look at it in a neuroendocrine way. Like, we need to actually take the time to integrate the care. And using that lens, we can put it to PCOS. We can use it for endo. We can use it for all of these other diagnoses that have differences and issues when it comes to hormones. And it's crazy that we just don't look at it that way.
I mean, to that point, and I know Dr. Say you had something to say too. To that point, and I know we're not talking about these populations, but pregnancy and postpartum, right? Your brain's changing there as well, hormonally, significantly. And studies have shown that the impacts of pregnancy and then going into postpartum can last up to 7 years for some individuals, those changes in the brain. And so, absolutely, when we start thinking about it in that way, in the neurologic or endocrinologic, uh, framework, then we can think about what would be preventative of that shrinking of the hippocampus, for example. What could we do to strengthen those areas of the brain in preparation for what biologically, physiologically happens? Yeah, Dr. Say, what were you thinking about it?
I was thinking about so to the point of the team approach, it is so important that different specialties are educated in the topics when we're talking about menopause, prenatal, postpartum, because I do feel like it becomes uh I'm not gonna say it's scary when practitioners are unfamiliar, but even one of my coworkers was like, "Hey, I'm having a vascular issue and I'm pregnant. Nobody at the vascular facility is trained in how to treat me." And I'm like, pregnancy has so many vascular changes that are occurring. Why is no one trained in this section? And so, to your point on menopause, to the point on the brain changes that come with prenatal postpartum, I'm like, yes, there should be a wealth of practitioners in the mental health and wellness field, in the, I'm going to say therapy services, so physical, occupational. There should be team approaches for most of these things.
Mhm.
And I'm like thinking of all of the different bodily changes that occur. I'm like, yes, yes, yes. It would be helpful to know ahead of time so that people don't think they're going crazy. So that people don't think, oh my goodness, I'm the only one who's going through this. It's like if you know ahead of time, at least like you said, you can do preventative measures. Not like, oh, I'm never going to go through menopause or oh, I'm not going to become pregnant. But just knowing, hey, these are things that can come up. These are my resources. And so with that being said, Dr. Dani, I'm curious to what do you think are some of the biggest limitations in women's health current treatments?
Ooh, I would probably put it into almost like three categories where I think a big thing is symptom suppression. Like we are so into, and please don't get me wrong on this. Like I do think a lot of things that we do are really good. But for example, with PCOS, endometriosis, we're talking about the importance of diet, importance of stress. While yes, they are important, but we're not really doing much to figure out like what the root cause is or how does it form
Mhm.
or kind of all these different treatments and interventions. Like especially with endo, we've excision surgery, but that's not a cure. You still can go back for more. It's still painful. You're still going to have all these things. So it's this suppression, and it's also, I don't even say that great suppression, but it really is. I mean, to still have a surgery to help with some of the symptoms, but not all of the symptoms, I'm sorry, but that's pretty radical in my eyes. And recovering from abdominal surgery, it's a lot. So we're just focusing so much on suppression, not even that well, rather than what is actually the cause.
Mhm. Mhm.
And I think that kind of tailors into this, like, there's such a lack of research, but also just specifically like women in research. Like, there's this long-standing history of like women when it comes to like pain. Oh, we don't want to think about women and pain and what happens. If we're looking at kind of these medical textbooks, they're like, what, studied on white men? Like, it's not even representative. So it's just, there's not enough research, there's not enough understanding on this. And we think we get to a basis of it and we're like, okay, cool. Like they're just going to be complacent and move on. And we're not going to be complacent. We're in pain.
Yeah.
That
Yeah.
that takes,
Absolutely. So, and like to that point though, I that made me think like, when do people come see you? Because I know that to your point of suppressing the symptoms, part of it is like that stress aspect of it. And it's like by the time it gets to that point, then people are seeking out maybe like psychology. I know as PTs, oftentimes we see our clients later down the line or almost at the end of the rope or when certain symptoms are compounding on top of each other, but we've not done a great job, I think, of finding out first of all what are the factors that most contribute to these these things like endo or polycystic ovarian syndrome, And how do we get people to providers sooner?
Hmm.
Provide
Yes.
strategies to prevent exacerbation or worsening of the symptoms that, yeah. So my question to you, I guess, is like, when do you start to see people, when do people start to come to you? Is it later down the line? Do you get to see people in the very beginning stages? How does that work?
I would love to give you the answer of like, oh, I see people early on and it's great. We have these conversations. No, like instant no. So usually I'm not seeing people, and I hate to like quote the literature on this, but like it usually takes four. We're seeing four now because of TikTok, Instagram. Nothing wrong with social media. It can be a great tool. It is not a doctor, so do not try, but it can bring awareness. But we're seeing people get diagnosed a smidgen earlier, which is great, but we're still looking 4 to 10 years. And part of, kind of a limitation too, and it connects to this, which is perfect, is like with this diagnostic process, there's not cohesive care.
Mhm.
So when we finally see someone, it's like they've been to medical for so long, and medical is bouncing them around to maybe physical meds, so PMRS or rehab service, then maybe it's to PT, and then maybe it's to like a neuroendocrine, and then maybe it's to an OT, and then maybe they're bouncing to us. So that's years of trauma, that's years of money, years of just misinformation, years of separation. And then we finally get you. And on top of that, it's this for so long, a lot of these symptoms are like, you're just anxious, like you're just sad, you're just anxious, it's just PMS, but it's not. So we're not even, and part of just early diagnosis matters so much because that validation, that connection with the body. And yet, because these are such still taboo topics, we don't get you until the very end, which is so damaging. And it's really just upsetting, to be quite frank about it.
Dr. Danny, Dr. Danny, to your point, yes, when you mentioned that they might even come to PT before they get to you, because I know at least for my patient caseload, it'll be like, oh, you've been seeing different providers for 6 years, and now today is the day you've made it to pelvic PT. I'm glad to see you. I do wish I would have seen you sooner or before you had the surgery or at least somewhere in the in between, because it does. It's like you want to know what expectations look like. And even to the point of different operations being like, you may get some symptom relief, but you might not get all of the symptom relief. And sometimes I'm like, did you know that? Did you understand that it can be a reoccurring thing? And I was like, chronic, when I think of chronic pain, pelvic pain and things like that, I'm like, it can be depressing, it can be anxiety producing. And so seeing a psychologist or some type of mental health provider is so important. Um, with those different delays, I'm curious as to I see different responses in the patient population, but what happens psychologically when someone is told everything looks normal and they don't feel normal, and then it's like, oh, the imaging didn't show anything, and I was like, it didn't show anything the last time, but you still had all this endo tissue building up. You were still passing out on the toilet. It's been a whole run, and so I'm curious as to your thoughts.
This is such a good question. I actually love this question because, like, so often we're told everything is normal and it's anxiety, or maybe you just need a little something sugar in your system and you're okay, and take a few deep breaths. And it's like, what we're actually doing is creating this, like, very deep psychological split.
Mm.
So when you're experiencing something like real pain, and real pain, real symptoms, and people over time consistently are telling you there's no explanation, it's in your head. What it's doing, it's eroding this trust within your body. It's
Mhm.
eroding and taking away that perception and understanding of yourself. So we start kind of getting those questions of like, am I exaggerating? Am I too sensitive? Maybe I'm wrong, which goes to this like place of anxiety and shame and hypervigilance where we're just consistently monitoring, which bidirectional influence, the more stressed we get, the more symptoms we get, and then the more symptoms we get, the more stressed we're getting. So the nervous system is now just learning that our body is not safe. It's not reliable. Like we don't know how to understand this. And we just become constantly alert, constantly in stress. And the core of this, which is like so simple to say, it's like diagnosis is regulating. And I'm not going to say it fixes everything because it's not, to the point is there's going to be imaging that we may not see, surgeries, PT, it's still going to be ongoing care, but it's validating the experience and it's really teaching your body that there is a coherent story going on.
Mhm.
And it's really difficult to navigate without a map. I mean, listen, I can't tell my left from right still to this day. I'm a it's embarrassing. But imagine trying to navigate different doctor's appointments, different pain, where you're told consistently, like, don't trust what your body's saying. It's incredibly dysregulating.
Yeah, it really is. It really is. And I wonder too, this is just kind of like a overarching question. Maybe you will have the answer to it, maybe you won't, but why are some women, or why are women in general so frequently dismissed and invalidated when it comes to pain, and specifically and particularly Black and brown women who are really frequently not validated in the medical space? Like, I mean, we can go into biases and things like that, but what's your take on that?
I hate to be the basic take on this, but it's just when it comes to gender bias, specifically in pain assessment, pain research. The most influential fact that I can give on this is there's about 30% of women that can have breakthrough pain during cesarean, and they're not believed.
Mm,
And that
Insane.
is
30%.
It's
insane.
insane.
And, and it's like that bias alone, this history of just not actually trying to understand women's in the pain, interpreting pain as like a psychological symptom rather than something physiological. And if we go back to the history of just general research, we are looking at minorities are often who we did the research on,
Right.
which is so, excuse, I don't want to curse, but I'm like, it's so inappropriate. I almost did, so I'm sorry. But it's like, it's so inappropriate. It's so messed up. And then actually, when we're getting into it, is we're creating these false narratives again of this people are less than,
Mhm.
that certain races are less than, that certain genders are less than. And we're continuing this in the research. And I've mentioned this before, and I feel like this is kind of becoming well-known fact of like medical textbooks still are on white individuals. They're based on men. So people are being so misdiagnosed because your symptoms are not common that maybe they are actually common, but we just lack the money, the research, the understanding, and the want to look at different folks.
Yeah, absolutely. And even if the want is there, research takes 7 years to hit clinical practice. And so it feels like playing catch up
Mhm.
forever and always.
Yes.
And it is. And to the point of men, when I think of men versus women, I'm like, we have so many different biological processes. You would have to do a study on both populations when we talk about the diversity of people in the study. Yes, there is a big difference between the hormonally, physically. There are so many differences. It wouldn't make sense to say, oh, we can generalize this study on men to all of the women. And then I'm like, when we're talking about different, we'll say racial, I know it's a social construct, different ethnicities, different backgrounds. There are so many different considerations that you can't just say, oh, because we did this study in this very specific population, we can now apply it to everyone. And to your point of people being less than, or people being portrayed as less than, or not feeling the same amount of pain. I'm like, the stigmas do so much harm. They do so much harm when it comes to medical practice and how people are treated. And even now I'm seeing all these videos on media. It's like, oh, you see this person screaming in pain, but they're probably not in pain. It's like, well, what do we think is going on here? It's like, no, you're probably fine. And so I do have questions on the stigmas, but I also have questions on what do you wish more providers understood about, I would say, the emotional toll. We could say endochronic pelvic pain.
Mhm.
Yeah, I'll just say pain in general.
I feel like if we look at chronic pain, what we're doing is take chronic pain and then take this chronic bias dismissal. And what we're creating is this continuum of like isolation, frustration, grief, feeling misunderstood. And what we're kind of missing here is, granted, I love talking about the physicalness, the importance of this, but we're missing like the impact on like relationships, identity, career, all of those things as well. So, yes, why it's important to treat the physical, it's so important to treat those other things that are going on. And I feel like providers don't pay attention to how stress builds over time and how emotional exhaustion builds over time and how burnout also causes like delays in diagnosis. I mean, imagine going to doctor's appointments over and over and over again when you're a teen because you believe you have PCOS or endo or, just some sort of chronic pelvic pain. For years, you're told it doesn't exist. So, of course, you're going to turn out into this burnout, this exhaustive state, this stress state. And it's like, we're not even like at some point we were all young women and like we're kind of teaching this like mistrust at such an early age. So it's this, I just wish more providers understood the importance of like validating at a young age the culmination of stress and like the understanding it's not just physical, it's also on like your identity, like your grief system, all these other things too.
Mm. As you're talking about this, I'm really wondering, kind of anecdotally, what other comorbidities or other diagnoses do you usually see? Because I know as pelvic health PTs, when we talk to clients, sometimes our subjective takes the entire eval because
Yep.
we have to get that full picture of what all is happening. And sometimes it's a place to express and vent and share frustrations about the stigmas that are placed on them, or about how many, providers, 5 to 10 different providers that they've seen, maybe. And to your point of like, that creates that exhaustion, that fatigue, that burnout. We also sometimes in our space see comorbidities of like chronic fatigue syndrome and things like that. What are you seeing in your practice when you're working with individuals with endo or PCOS?
Probably so similar, to be very frank. So there's a couple different ways I'm going to throw that or kind of throw this to the wall, spaghetti on the wall per se. So we usually are going to say there's going to be some sort of adjustment disorder going on. So whether that is stress related to anxiety, to depression, to just not understanding your place, true grief. So mental health wise, I'm always going to give some space to that. We're also kind of noticing more in the research now too that we're seeing ADHD pop up into play, which is really interesting. And associated with ADHD, we're seeing a little bit more OCD and a little bit more anxiety also play in. So we kind of have these two really interesting bubbles in the mental health space.
Mhm.
And physically, so what's really a lot of the new literature, especially on endometriosis, is pulling it into the realm of connective tissue disorders. So we're looking at like EDS and POTS and MCAS. We're looking at autoimmune disorders. So, lupus, RA, all of these other things. And I hate to, please don't say this. I'm not a medical doctor. I am a psychological person. But if you are flagging with one of these diagnoses, looking at the other umbrella is so important because so often we're just throwing all the symptoms into one space where it could be something else. Endo also has a relation to Crohn's. Like, not many people even talk about that per se as well. Then we also see different for individuals who are very into like working out because of the way your pressure and your body just kind of holds and tightly wraps around your uterus. We're seeing different strains, different pains. We're seeing, and that to me is just so interesting. Where I've had a patient that I worked with, she's had 3 excision surgeries, and what she kept going in for was actually chronic fatigue syndrome was kind of one of these things that was popping up. And also she kept having these really unique pulls in her hamstring. And it was just going back to how her stress was just wrapping around her uterus and her hips were constantly tight. And she was like, I don't even really lift that heavy. I'm doing like the Stairmaster every day. And yet I'm still getting these pulls. So we're forgetting how much of these are really these full body diagnosis, and we should be curious and we should be looking into how they connect to other things.
Mm.
The leading with curiosity is it. Dr. Val, I know you have commentary as well. But when you mention, yes, the hamstrings, yes, the uterus, I'm like, even in the pelvic health world, I'm like, if we are not looking at the surrounding areas, because people are like, the pelvic floor PT, they're gonna poke me. I know, I had to say it because this is the inquiry on Google. But it's like, we also are checking your hips. We're also checking your spine. We're also checking your systems history because so many things are interconnected and related. And I love that you did the breakdown of the connective tissue disorders, because I think of like allergies, eczema, asthma, they run in a gang. And so if you see one, typically it's like, oh, let me cue in to notice if any of these other things are going on. If we did the same thing with a lot of these connective tissue disorders, I don't, well, I should say, I think people might have either a diagnosis or a treatment plan earlier rather than being dismissive and saying, oh, it's nothing, you're just tired. Or, oh, it's nothing, your hamstring just gets pulled randomly. Because sometimes, even in the clinic, I'll see something and I'm like, this is an odd presentation. Have you followed up with anyone? And sometimes the answer is yes. But they told me I didn't have this. And it's like, well, circle back. And then it's like, oh, now you do. And it's like, no, you always have actually had this issue. It's just somebody's able to pick it up now. And so I'm like, it's an interesting run. Dr. Val, I know you were about to give commentary as well.
No, I was really just I was going to give commentary and then I was just like soaking in all of the things because there are a lot of thoughts going on in my head, like the autoimmune aspect of it too, especially with the body building this split kind of process and this negative feedback loop that happens. We see the same thing happen in a lot of neurologic conditions. Dr. Danny, I know you know what I'm talking about, which is why I'm just like, man, with providers out there, I hope that any provider that is listening can pause to assess how they are looking at patients, and really assess what it means to do so holistically. We throw that term out so flippantly sometimes, holistic care, but like what actually is that, right? And I think it is exactly what we're talking about right now. It's such a critical piece. We're talking about this connection between the connective tissue and the pain and the clenching and the stress and the holding of your body in a particular way. We're talking about compounding some symptoms that could also fit in other buckets. We're talking about things that go together hand in hand, like eczema and allergies and things. So I'm just, I'm just like, I want to implore any practitioners listening, that we get it. We're also practitioners and we have to have this in the back of the head every single day as we're talking to our clients. So, yeah, my brain is just moving in a thousand directions in thinking about this. And um, Dr. Danny, even your mention of ADHD and the prevalence there. Wow. Like, it makes sense when you say it out loud, and I'm sure that you can go into a deep dive probably with us on what that correlation is. We'll have to have you on a part two for sure. But yeah, I mean, I think I'm just marveling at the connections that we're making here. Yeah. So I think, Dr. Danny, I want to make sure that we definitely get you back for a part two. We have so many things to discuss and so many questions we still have. But if you could leave our listeners with anything related to endo or related to PCOS, or any reproductive health disorders, what would you leave them with?
I feel like I need a second to actually think, but I know this is going to sound really basic, but it is loss isn't tangible.
Mm.
So, more of what I mean is for over time, when we are talking about kind of normalizing women's health and just talking about women's health, we're not just talking about either pregnancy loss or fertility struggles or hormonal changes. Like we're also just talking about the loss of expectations. So we're talking about, loss of time, of career momentum, energy, sense of self, connection to trust in the body. So leaving off, it's this, what you say and what you feel matters. And I know it's such a small and basic statement, but if your body is telling you something, slow down and listen because it's telling you something for a reason.
Mm. Absolutely. It surely is. Yeah, no words, no notes. That was
Oh, I was
perfect.
like, that was not basic at all. That
No,
was a valid point.
it
And
really
I
was.
hope to help people find some healing even in that statement. I was
Mm.
like, it is important to be validated. And yeah, the loss being intangible, I need that to be a quote.
Absolutely, absolutely. So, Dr. Danny, how can our listeners connect with you?
So right now I'm working with this fantastic health focused psychology company. We are called Evolve. And so we have a handful of other clinicians who are all super skilled when it comes to all health psychology needs. So feel free to drop us a line at info@evolvin, so EVOLVINN.com. Feel free to go to our website, check us out, drop us a line on there. We are pretty easy to contact.
Amazing, amazing. We will definitely have all of that info in the bottom comment section and the captions of this episode. We are so, so grateful to have you here. We definitely are going to hit you up for a part two. You're quite incredible. Thank you so much. And to all of our listeners out there, stay balanced, mamas. We'll see you next time.